Post-Polio Syndrome. In the first half of the 20th century, a plague of paralytic poliomyelitis disease seemed unstoppable. A major epidemic of polio hit the New York area in 1916, and in the following decades, epidemics grew in size and became more deadly. The epidemic of 1952 affected more than 50,000 Americans and had a mortality rate of 12%. This infectious viral disease can strike at any age and affect a person's nervous system. After a vaccine came out 6 years later, it seemed the disease had been vanquished. Most survivors of polio who thought they had beaten the disease went on to lead highly successful and fulfilling lives. Years later, however, many began to experience new symptoms, including new weakness, fatigue, joint pain, decreased endurance, and difficulties with daily living. By this great deal of people experiencing the late effects of polio, it started attracting the attention of the medical community, and in the early 1980s, the term post-polio syndrome was created. Pathophysiology. The cause of PPS is still unknown. However, it is widely accepted that degeneration of the motor neurons, likely caused by overuse, is responsible for new muscle weakness. It is also clear that this new weakness only occurs in the muscles originally affected by the poliovirus. Post-polio syndrome is considered a slow progressive condition. Humans are the only host for the disease. The virus specifically targets the motor neurons of the anterior horn cells of the spinal cord and the brainstem. Its multiplication is responsible for an apoptosis of the affected motor neuron. Studies of patients with PPS have revealed an ongoing denervation reinnervation process. This is initiated after the acute poliomyelitis disease and over time leads to increased motor neuron unit areas caused by collateral sprouting of adjacent motor neurons in the spinal cord of people with PPS. The motor neuron area might increase by up to 20 times, reaching a level at which further reinnervation is no longer possible. Uncompensated denervation causes atrophy of muscle fibers and subsequently loss of muscle strength. The underlying cause of the ongoing denervation resulting in the motor symptoms of PPS is unclear. However, this is the leading hypothesis after several being proposed. Signs and symptoms. Post-polio syndrome is composed of manifestations that can be classified as systemic, musculoskeletal, or neurologic. Because the systemic manifestations are nonspecific, the syndrome itself can be hard to diagnose unless the musculoskeletal or neurologic component also exists. To properly diagnose a person with PPS, not all symptoms and signs need to be present. Prior paralytic poliomyelitis can be a symptom of PPS with evidence of motor neuron loss, signs of residual weakness, as well as atrophy of muscles on a neurological examination and also signs of denervation on electromyography. Another sign of PPS is gradual or sudden onset of progressive and persistent new muscle weakness or abdominal fatigue levels or muscle and joint pain. These symptoms will persist for at least a year to be properly diagnosed. Less common symptoms include new issues with breathing or swallowing. Effects on mood and control. Post-polio syndrome is rarely life-threatening, but the symptoms can significantly interfere with an individual's ability to function independently. A number of neurophysiological etiologies have been hypothesized for the late onset of deterioration of function and neuromuscular function in post-polio patients. These effects may play a role in affecting the patient in their ability to control movement. While motor dysfunction is the main feature of the condition, generalized fatigue, sleep disturbance, decreased endurance, neurophysiological deficits, sensory symptoms, and chronic pain are considered quality of life implications in PPS. Many PPS patients may resist implementing lifestyle modifications, including exercise, due to these effects the syndrome has on the body in relation to movement control. Treatment and interventions. When prescribing exercise for the individual with this syndrome, it determines recognizing the unique factors that they may attribute. Consultation with their GP must occur, as well as specialists in rehabilitative medicine, such as physical therapists and occupational therapists, may help in formulating a specific management plan. There are currently no effective pharmaceutical treatments that can stop deterioration or reverse the deficits caused by the syndrome itself. However, there have been many evidence-based interventions conducted that explore the effects of exercises for individuals living with PPS. A number of these studies have demonstrated that non-fatiguing exercises may improve muscle strength and reduce levels of fatigue. Pain, weakness, and fatigue can result from the overuse of muscles and joints. These same systems also can result from disuse of muscles and joints. This fact has caused a lot of misconception about whether or not to encourage exercise for individuals with PPS. A study conducted by Anderson and Grimsby explored the effects of well-controlled high-intensity strength training on muscle functioning of PPS patients in Sweden. Patients experienced no negative side effects after completion of the training program. They also reported that for many of the patients, it was easier to perform daily activities such as standing, climbing stairs, and walking. Treatments and interventions. Exercises can be beneficial to people with PPS when the exercise is performed without causing the patient to experience undue fatigue or increased muscle or joint pain. An effective SACE exercise program may consist of 3 or more days of exercise per week, including the following components: a light warm up, gentle stretching and strengthening exercises, gentle aerobic exercise for cardiorespiratory fitness training, and conclude with stretching and cool down exercises. Throughout the exercises, the individual should be instructed on the importance of avoiding excessive fatigue or muscle and joint pain. Thank you.